What is up, everybody? What is up? This is Dr. Andrew Kim, MD, here on the Insomniacs Livestream on my YouTube channel. Thank you for joining in. Happy New Year to everybody. So, welcome for those of you who have checked in before. I thank you for your support to all my subscribers out there. For those of you who are tuning in for the first time or listening to this after being recorded, please remember we do live streams on Saturday nights and Tuesday nights at 10:30 Central, 11:30 Eastern. So if you haven't subscribed already, please subscribe to my channel. I still put out evergreen videos as well in between the live streams. So let's get into it today. So today we are going to be focusing on some novel treatments, okay? Novel meaning new. So different treatments for difficult to treat depression. Okay, so rather than talking about what most of our society, most people are already familiar with, most people are familiar with SSRIs or selective serotonin reuptake inhibitors, Prozac, Zoloft, Paxil, Lexapro, etc., etc. Many of you are either on these already. Many of you know them, have been on them before. You know a loved one or a friend or an acquaintance who's on it. So rather than bombard you with the same old, we're going to be talking about kind of atypical, non-standard treatments. So these are treatments that typically are thought of after the fact, after someone has tried several SSRIs, just so that you can be aware. I want to just raise awareness, maybe make you aware of treatments that are available that you might want to consider. A loved one of yours, your spouse, your child, your parent, your cousin, your friend might want to consider if it's never been brought up before, just so that we can expand our minds and expand our knowledge base. So what are we going to talk about? We're going to be talking about things like ketamine, or the nasal spray version of ketamine called S-ketamine. We're going to talk about we're going to talk about magnets. When I say magnets, I'm being serious. There's an FDA-approved treatment out there for clinical depression or major depressive disorder called Transcranial Magnetic Stimulation, TMS. We'll talk about the ins and outs of that a little bit. We're also going to talk about some of the stuff that's on the horizon. We're going to talk about psilocybin, or as most of our society knows them by, more so the colloquial name, shrooms or mushrooms, okay? We'll also talk about the most recent failed trial of MDMA, or again, better known as ecstasy. MDMA trials for PTSD, unfortunately, KG 10 to the 5, he says TMS FTW. We're going to talk about what happened. Why was this hyped up, excited treatment about MDMA or ecstasy for PTSD? Why did it get halted in its track? Why did it stop? And what does that mean for the psychedelic clinical trial train with all these psychedelics that are on the horizon? So let's talk a little bit about all of the above. That's what we're going to get into today. So again, please please subscribe. And if you have any questions about some of the things I talked about, ketamine, nasal spray as ketamine, TMS, psilocybin, throw out questions as we move along. But before we dive into that, how are your 2025 New Year's goals going? So for those regular listeners, I know some of you joined and some of you gave me some of your goals. How are you? I know we're only 4 days into the new year. How are you guys doing on your goals? One of my goals was to work towards something I value, health and fitness. Okay, I know that's very generic, right? But part of that is trying to get more physically active, because I could count on one hand how many times I worked out in 2024. Okay. So the way I'm trying to go about doing this is just being more physically active. And one of the ways I'm trying to do that is, at least right now, I don't know how long it'll last for. So I'm not going to make a rule, and I'm not going to put myself into a rigid mindset that I'm going to have to do this 365 days for the whole year. But at least for the month of January, I am going to try to use, I have a Peloton that has basically been collecting dust, okay? But I am going to try to use that regularly for the month of January. We'll see if I get sick of it, I don't get sick of it, but I'm going to try to do it for the month of January. So far, I've used it 3 times, 2 for actual bike rides, 1 for a meditation kind of cool down recovery session. So I'm trying, guys. I've probably the 3 times I've been more active and worked out this year is almost the equivalent to what I did in 2024. So it's a low bar, but it's something. But how are your goals doing? So if you guys were listeners at the previous episode where you were talking about goals, put those in the chat as well. So let's see. I got a couple comments here before we dive into it. So Dennis has been a regular listener. Dennis says, regarding MDMA, I do believe that there is significant potential. However, I think the main thing is to encourage the FDA, DEA to get out of the way of human trials. Well, yeah, you're right. We'll talk about that, Dennis. I think you do have a point. Obviously, I do think there's got to be a balance, right? There's got to be some degree of regulation because there's got to be safety. Because trust me, and I'll get into it, some of my past history. I used to work as a principal investigator, fancy term for a physician who is leading a clinical research center or research trial site. That's the person who's basically responsible for everything, meaning if something goes wrong, if something unethical happens, if something unsafe happens, someone gets harmed, someone dies, that's on you. That's the principal investigator is responsible for everyone and the entire conduct of the trial at that clinical research center. And we do need rules and we do need regulations to keep things safe, because even with the current set of rules, trust me when I say there's tons of shadiness that happens. So, but I also agree with you. I do think it has become overly cumbersome. I mean, overly cumbersome to run clinical research, that it makes it nearly impossible in my opinion, for the little guy to make breakthroughs. Unfortunately, to go from bench science to actual FDA approval, my numbers might be a little off, but I mean, we're talking hundreds of millions of dollars from start to finish. Okay. And that's not even including marketing and all those things that happen after approval, but hundreds of millions of dollars. So why is it no surprise, right, that all you see are the same olds, right? The Takeda Pharmaceuticals, Johnson & Johnson, Otsuka in Japan. Like it's the same 7 or 8 players that just continually to pump out all the treatments in the world, because who can take a gamble with 200, 300, 400 million dollars from start to finish to run a clinical trial? Because trust me, Dennis, you are correct. There is so much bloat. There is so much bloat in the clinical trial space. There's so much bloat in this middleman industry of regulatory quality control in clinical trials. It's become its own cottage industry in itself. Everyone wants a piece of the pie, that it's so impossible to run a trial from start to finish. But so you do have a point. We'll get to that later. So Chuckles, thanks for joining. Chuckles says, any of these help social anxiety? There are some trials coming up where they're looking at things like Psilocybin, MDMA, that are targeted in the anxiety realm. So PTSD, anxiety, OCD. So it's to be determined. So Dennis also adds, there's absolutely no reason for it to be as difficult as it is to run tightly controlled studies on drugs of abuse. Yeah, you're right. Again, it comes down to probably an over tightening of safety when people hear the word controlled substance. You're right. But again, there's got to be a balance. So, and Carrie's a regular listener. Thank you, Carrie, for joining. And then we'll get into it after this. This was the final flurry of initial questions. What do you think about over-the-counter supplements like 5-HTP or tryptophan? Have you ever prescribed those instead of SSRIs? Yeah, we'll get into that. So, yeah, let's talk about that before we dive into the meat of today's discussion. I am definitely not one of these physicians who's like prescriptions versus supplements. So I want to make that super clear. I'm not. Okay. There are supplements that I recommend. Some of the ones I recommend often are melatonin for very specific sleep scenario, insomnia scenarios. Again, very specific scenarios. I don't just believe in it that it works across the board for everything. I do recommend something called N as in Nancy, NAC, N-acetylcysteine, very long, so that's why we just call it NAC, I recommend that for some of my patients for OCD and for compulsive disorders. Mixed results, even though it's not FDA approved, there are mixed result studies by OCD and compulsive disorder specialists that have shown that not everyone's going to benefit, but there's a cohort of people who benefit from mega kind of high doses of NAC for the off-label, meaning it's not approved for it, but we have enough evidence to say that for a percentage of people, it will help things like OCD and compulsive disorders. So to your question, so just giving you context, there are certain things that I will recommend. Now, and KG10, yes, exactly. Thank you. And that's the full spelling of N-acetylcysteine that KG put in the chat there. So I will say, for when it comes to serotonin-based agents for depression that are over the counter, if there was one, I mean, like St. John's wort is something, I almost equate that to nature's SSRI. Okay. And this is why, and I really mean this. This is why there has to Dennis's point, I believe what Dennis said about the controlled substance drugs, right? Like MDMA, shrooms, like we should also apply that to the supplement industry, right? And this is my frustration with the supplement industry, okay? There are definitely medicinal properties. There are definitely medicinal properties that are capable of being harnessed by some of these things. Like St. John's wort truly has SSRI mechanisms, okay? Here's the problem though, right? So if a patient said to me, I'm in a pinch, I can't afford my prescription was. Now, here's the thing. In this day and age, this is why I don't, because I don't recommend St. John's wort, simply because even without insurance, okay, you can get a month's supply of fluoxetine or Prozac for about $4 a month. If you use mail order pharmacies like Cost Plus Drugs, sometimes you can get it for it'll come out to maybe $7-8 for a 3-month supply. It actually ends up coming out cheaper than you probably taking St. John's wort. So that's where it becomes more of a price concern. Like these supplement companies have literally even priced themselves out from SSRIs, at least certain generic SSRIs. Can you believe that? But it's true. Like some of these supplements are going to cost you more per month than it does for a month's supply of some of these generic SSRIs. Now, obviously, the rate limiting factor is where can you get that prescription from, right? From the physician without costing you an arm and a leg for a physician visit if you don't have insurance. But if you can figure out a way to get a prescription, from a physician, whether it's through, some kind of sliding scale clinic, through your Medicaid, et cetera, month to month, you're actually going to pay more for some of these supplements. But back to my point though, here's the thing though, Carrie, like St. John's wort, yes, it has some SSRI mechanisms. The problem I have is because the supplement industry skirts and goes around the FDA because they're marketing these things as dietary supplements, not medicinal treatments, right? They don't have to prove anything. And this is why you see commercial ads. You could see things even on the labels or the boxes themselves, print ads in magazines. Take this for your depression, take this for your anxiety, take this for that. But in the fine print, it'll say, these claims are not proven. These are not FDA-approved treatments. These are not meant to be marketed as medicine. These are dietary supplements. Yet they could say whatever the hell they want, right? And because of that, again, there's also such variance in potency, purity, all these different things from one brand to the other. Look, again, prescriptions have a problem. One generic manufacturer from this factory, one generic manufacturer from this factory, there could actually be, close to almost like a 30% variance. As long as you're within about 15% variance from the original patented formula, you can get approved as a generic. So meaning, what if one was like 10, 15% in this direction and one was 10, 15% in this direction from the original formula? You can actually get some variance from one generic manufacturer to another. So that's even with regulation. That's with tight regulation from the FDA. So now imagine You circumvent that with all these supplement companies, okay? And there's no one overseeing this, right? So, there's concerns about dosing, potency, accuracy of those things. There is not a ton of rigorously done studies. I'm just going to say it. People can vehemently disagree with me. Just because you can Google and find 500 studies, it doesn't mean crap to me if 499 of them sucked and were poor quality studies. Like, it's the quality of the studies that make a huge difference. And I'm sorry, but like most supplements out there, they don't want to run these studies because, number one, there's no incentive. They don't have a patent for these specific, compounds and chemicals. Number two, I don't think they want to invest millions of dollars to show that they had equivocal results, marginal results, etc. They don't have to prove anything to the FDA. So there is literally no incentive. They already have the ability to market and say whatever they want. They have the ability to sell it. People will buy it out of desperation, out of hopefulness, and they can circumvent all of the tight regulations that Dennis was referring to, that the FDA has for medicinal treatments. That's the problem. Now, 5-HTP or tryptophan, I actually don't have a lot of faith in those per se because it gets a little bit more complex. I think the pharma industry, I'm going to blame the pharma industry. The pharma industry did a really good job in the 80s when Zoloft came out. And Zoloft, the manufacturers of Zoloft did a really good, and we had an episode on this. We talked about direct to consumer marketing. And there was a huge boon of that in the 80s. And the makers of Zoloft were some of the ones who really propagated this idea to the community and America and to physicians. We just have to rebalance the chemical imbalance. Serotonin goes up, you get happy. That's myth. I'm sorry. That might be a process that occurs in the process of trying to treat depression, but that's not the end point. And that's where 5-HTP and tryptophan makers, they love that. They piggyback the mythology that pharma has created to their advantage because now they're not regulated. They could say whatever they want and it's natural, right? And here's what I mean. It goes beyond simply boosting serotonin levels in your serum. Because here's the thing. If I gave someone a dose of Lexapro, a dose of Prozac, within hours, detectable serotonin levels will increase rapidly. But do people's depression and anxiety resolve in hours? No. Traditionally, we say you got to get to a therapeutic dose. And once at that therapeutic dose, may take 6 or 8 weeks. If that med even works, if that's even the right dose of that med, it will take 6 to 8 weeks. Meaning there's a lot of other steps and secondary things that happen with chronic exposure to an SSRI or St. John's wort, etc. So simply taking something that essentially just raises serotonin levels itself is not going to be enough, in my opinion. Then I don't want to get into minutia, but then talking about crossing over the blood-brain barrier, that's another factor, and a lot of the over-the-counters don't do a good job of that. Most of them will literally get chewed up in your gastrointestinal tract, and minuscule amounts, if any, are even going to be available here, which is something that a lot of these manufacturers don't want to talk about either. Anyways, okay, let's dive into it, guys, and keep the chat coming, and then I'll try to get around to the questions as we take breaks. So let's get into the first grouping of treatments. We're going to talk about ketamine and S-ketamine. I'm going to give you a disclaimer here first, okay? Very quick. I want to be transparent with you guys. I used to be a principal investigator. I was one of the researchers that recruited patients into clinical trials at a clinical research site in the Chicago area for the nasal spray version of S-ketamine. Okay. And after that, I have been a member of Johnson & Johnson's Speakers Bureau that has gone around to train other doctors and nurse practitioners across the country about its appropriate use. So I want to be transparent. I also want to say I have a brain, okay? Meaning I can also give fair and balanced presentation. I'll be the first to say nasal spray ketamine, intravenous ketamine, these are not silver bullets. They're not going to work for everybody, okay? This is not a panacea to treat difficult to treat depression. So if anyone says just because I've been involved in pharma or I've been on a speaker's bureau that I can't give a fair and balanced presentation. Well, I don't know what to tell you. Apparently, you're not someone who's been able to utilize critical thinking. Will it bias me a little bit? Sure, of course. I'm not immune to bias, but I also like to think I'm smart enough, educated enough to know that I can give a fair and balanced presentation on something. And I try to be a physician that would only talk about things that I actually back up and believe in. I've been asked to do speakers bureaus for 30 other companies, and I've said no, because I'm not going to talk about something that I don't really have passion about. So want to give that disclaimer. So let's talk about ketamine. When you say the word ketamine or S-ketamine, right, people freak out. A lot of people say, well, that's a street drug, right? Why the hell are we going to give street drugs, drugs of abuse, as Dennis put it, to people for depression? Well, let's talk about the history. Okay, for those of you who are not familiar, for those of you who aren't in healthcare, some of you are, ketamine obviously started off as an anesthetic agent, right? Anesthesiologists would use this, sometimes in the pediatric population even, okay? Then obviously it's also been a drug of abuse. Patients do abuse ketamine or ketamine derivatives to dissociate, to alter their sensorium, to go down what's called a K-hole and go on these like trips. Want to be clear, the doses that are going to be used in the realm of clinical depression are minuscule compared to anesthesia doses, are going to be, much smaller. We're not trying to abuse them like street abuse, so they're going to be much smaller doses than what's used there. And this has been something that's actually been studied now, specifically in the realm of depression, since the late 90s, mid 90s even. Okay, so there's essentially at this point close to over 2 decades of research in ketamine. So obviously, look, I am not your personal physician. This is for educational purposes, so let's get that out of the way. I'm not giving you direct medical advice, but this is to increase knowledge base and awareness. IV or intravenous ketamine and nasal spray S-ketamine. So S is ES before the word ketamine. S-ketamine basically just means you took a carbon chain, you flipped it. That's called an enantiomer. So they're essentially the same parent compound. One is delivered by a nasal spray, one is straight into your veins with an IV. I don't want to get into minutia and bog us down with mechanisms, but the mechanism, what makes this different and novel, this is not an SSRI. So this is not about blocking the reuptake of serotonin from one nerve cell to the other. That's not what we're doing here. So to put it, this is an oversimplification. You can simply go on PubMed or a Google search and you'll find much more elegant explanations. But for the sake of time, what we're trying to do with ketamine-based interventions, whether IV or nasal spray, is we are trying to modify or modulate the transmission of a very different chemical system called glutamate. Okay? Glutamate. Glutamate, glutamate. Okay? And this is an oversimplification as well, but our brain typically has these 2 chemical systems that are in this homeostasis that go up and down. Glutamate is kind of an excitatory signal, and GABA, G-A-B-A, is a kind of slow down inhibitory signal. That's an oversimplification. But glutamate is essential in cognition. It's essential in mood regulation. So glutamate is a very ubiquitous chemical system within our brain. Okay. So ketamine is believed to modulate glutamate transmission. This is also theoretical, but it's also believed to more potently enhance something called B as in boy, BDNF. B as in boy, D as in Delta, N as in Nancy, F as in Frank. BDNF, brain-derived neurotrophic factor. Okay, what does brain-derived neurotrophic factor do? Interestingly, it helps the areas of our brain that have what's called plasticity, the ability to change and fluctuate and heal itself. It enhances neuroplasticity. Fascinating. So why is that important? So this is an interesting finding. This is fascinating. So for those of you who are on the chat, I see at least 12 of you here right now. Go look up on a Google search, just so that you can see the images. I wish I had an image preloaded here. Go look up the terms depression, hippocampus, Hippo, hippocampus, plasticity. Okay? Depression, hippocampus, plasticity. We have two areas of the brain at the base of our brain on both sides, on the right and left. It's called the hippocampus. And if I were to do a very impractical, expensive scan at a fancy academic center, okay, and I caught somebody at the valley point, the worst point of your depression. I mean, you are in the thick of it. You are hopeless. You are dysphoric. You are the worst of your worst. Okay. Interestingly, we will see that you have lost nerve cell density. The dendrites are less dense in the hippocampal regions of your brain. And the hippocampus is involved in certain things. It's not like the one spot that controls all these things, but it's involved in the processes of concentration, something called working memory, meaning if I asked you to learn something new, spit it back to me in like 6 to 8 minutes, that's called working memory, okay? So interestingly, right, I just said when you're at the worst point of your depression, oftentimes many patients have a finding where that area actually has lost density of nerve endings or dendrites. So it's also interesting that if I gave you a battery of cognitive tests during that valley point, you would not perform as well. You wouldn't be as sharp, your processing would be slower, memory would be off, you wouldn't perform as well on standardized tests compared to when you're at your optimum. So fascinatingly, I mean, we're talking old, early DSM. They used to call, a century ago, they used to call clinical depression pseudo-dementia. That was one of the terms they used, pseudo-dementia. Because they said, this isn't Alzheimer's, this isn't dementia, but this person is so depressed, and while they're so depressed, they almost act like they have mild components of a dementia. So fascinatingly, we had some savvy clinicians over a century ago, without the benefits of MRIs and fancy scans, detected that cognitive inefficiency and cognitive dysfunction was a part of the presentation of really bad depression. Now we actually have the biological correlates to show a relationship between organic biology and the clinical findings that we observe. Okay? So why did I get into all this? Back to what I said, BDNF. If we can find some of these chemical agents and treatments that can promote potently BDNF, we can then hopefully more rapidly accelerate what's called re-arborization is the term they use, because these nerve endings almost look like branches of trees. So they say re-arborization. Can we actually make those dendrites, the nerve endings, dense again and accelerate the healing in the hippocampal regions? And we have been able to demonstrate this. And interestingly enough, this is the fascinating part, right? And this is where I'm saying there's still so much unknown. There's so much unknown. These textbooks and these beautiful images on Google make it seem like we understand this. We don't understand this, okay? When someone is improved with their depression just from time alone, from therapy, from an SSRI, from ECT, from ketamine, we can see that change again biologically, meaning in that hippocampal region, we can actually see those nerve endings come back and be dense, meaning it's fascinating. Plasticity, we can see changes in a concerning direction. We can see changes in an improved direction. So that's what we mean by plasticity. We can actually see organic change in both directions. And then again, if I gave you a battery of standardized tests, you'd perform a lot better with those nerve endings being dense again in the hippocampal region. So again, this is exciting stuff, but still a lot of unknowns. But we believe that this is an area that needs further research. And this is why more and more drugs that are in the pipeline are being looked at that try to promote the expression of BDNF that much more potently. So, okay, that was long-winded, but it's really more to hammer the point that ketamine or S-ketamine are very different than SSRIs. This is not about modulating serotonin. It's about modulating glutamate. It's about modulating and enhancing the signaling of BDNF. Now, what does that translate to? It translates to, interestingly enough, we can get more rapid responses. These are the traditional principles of SSRIs, your Prozacs, your Zolofts, your Lexapros, is that you got to get on a minimum therapeutic dose, okay? And there are ranges for each one, and you got to be on that therapeutic dose for 6 to 8 weeks, okay? Again, if, not everyone is going to, but if you are a responder to IV ketamine or nasal spray S-ketamine, you might feel, okay, I didn't say remission, but you might feel improvement even after one dose. There are plenty of patients who say they feel at least some semblance of improvement even within the first 24 to 48 hours of their first dose of either IV or nasal spray ketamine. Now, most of the trials were what they considered a primary endpoint. They consider for the nasal spray an acute course of treatment 4 weeks. So the hope is with the nasal spray version of ketamine called S-ketamine, the brand name is some cheesy name, Spravato. Their hope is that at the 4-week mark, you can achieve what SSRIs can achieve in 6 to 8 weeks. With IV, a little bit faster. Some will say 2, some will say 3 weeks, that you're hoping to achieve a similar response to what SSRIs can achieve in 6 to 8 weeks. So those are the interesting positives, that it's a novel treatment, it's something different, so you don't feel like you're rehashing the 8th iteration of SSRIs. There could be a faster response time. Another huge benefit, in my opinion, is the lack of sexual side effects. Any of you on this chat who has been on an SSRI or knows someone who's on an SSRI, there's probably a greater than, I would say, anywhere from a 20-something to 40% chance you've had some sexual side effects. For men, that can mean erectile dysfunction. It could mean delayed ejaculation. It could mean almost like an anesthetic feeling, a loss of sensation in the genital region. Decrease in sex drive itself. For women, similar things. Not as excited, decreased libido, anesthetic effect. Harder to achieve an orgasm, not as pleasurable. Those are astounding stats, okay? I said 20-something to 40%, meaning almost half the patients who take these will get that. That is why it's the number one. It is the number one reason why people say, can I try a different one? Can I get off this? Okay, and for some, they have to make a difficult decision because they say, look, the benefits are keeping me alive. The benefits keep me functioning, being able to get up to provide for my family, but I'm having sexual side effects, and they might have to grapple with, is it worth it to stay on these or not, right? So one of the benefits of non-SSRI interventions like ketamine, IV ketamine, nasal spray ketamine, they don't really seem to have a high risk of that. I'm not going to say 0%, but I'd say minimal risk of sexual side effects. Now, what are the cons, right? What's the catch? I just said rapid response, shorter time frames, lack of sexual side effects. So let's be balanced and let's be real. A lot of it's going to come down to cost and accessibility, time commitment, and then we'll talk side effects, all right? Then we'll talk about some interesting offshoots about this topic, and then I want to hear your opinions on this as well. I'm going to take a pause after this. What do I mean by cost and time commitment and accessibility? Here's the problem, guys. This is the problem in the field of mental health, and it's probably similar in all fields of medicine. It's crazy. IV ketamine intravenous has been around longer than a nasal spray, okay? So IV ketamine is not FDA approved, okay? It is not FDA approved for major depressive disorder or clinical depression, okay? Why? Well, it's a complicated reason. I would say IV ketamine has been around for so long because of anesthesia, right? So it's already generic. So no drug company wants to invest hundreds of $millions to come up with some stupid patented spin-off of IV ketamine for clinics to then just buy an $8 bag of IV ketamine, because IV ketamine is generic and it's cheap, right? So there was one company, AstraZeneca, did some trials that got, very close to getting FDA approved, but I'm just going to say they just ran it so poorly, and the design was so dumb that even the placebo group was getting so much better. They couldn't even separate. So they just said, screw it. We're not going to redo it. And that's a travesty. Okay. It's a travesty because, again, now IV ketamine does not have an FDA approval. So now it's a cash only business. It's a cash cow. Okay. So sadly, if you want to access IV ketamine, I'm sure most of you who live in metropolitan areas, especially Chicago, LA, New York, Atlanta, Miami, like you hear tons of radio ads about ketamine clinics, right? Problem is, depending on your locale, getting one dose can be on the low end. If you're lucky, I've heard of it, but these are more like rural areas. I've heard of people getting might be like $300-$400 a dose, but in the Chicagoland area, it could be like easily $700 a dose, easy. And you're probably going to need, at least in the short term, for like the first few weeks to really know if this is going to work for you. Probably, I would say, like, in my opinion, at least 6 sessions in the first, in the acute course of treatment to see if this is even worth it to you to have any kind of like further maintenance courses. But so you're talking multiply like 6 times on the low end, $300-$400, 6 times, $500, $600, $700 a pop. It's a ton of money, guys. Right. The other concern I have with IV ketamine, and some people are going to vehemently disagree. I don't care. Screw you, whatever. Some of these clinics aren't even run by people in mental health. I mean, they're run by interventionists, right? Meaning they're ER doctors, they're pain specialists. They just know how to set up an IV. They know how to do procedures. They see the writing on the wall. This is a cash cow. This is not covered by insurance. So we're just going to pump you full of ketamine. But, are they even really assessing things for improvement, good response? I shouldn't be so... I guess I shouldn't stereotype so much. I'm sure there's people who have some nobility out there, right? But trust me when I say I've run across plenty of patients who I've received on the receiving end who've told me, oh, I've been getting treatments, for a year. And I said, oh, is it working? No. I'm like, why are you still getting it for a year? You should have your answer in 2 to 3 weeks if you're doing IV ketamine. Like, they just told me to keep coming back. I said, the psychiatrist just told you? They're like, no, it's not even a psychiatrist. They're like, it's some other mental health clinician. They just keep telling me come back. And I'm like, how do I break it to you? Okay. You should have responded much faster. So trust me when I say there's vulturing going on in the IV ketamine industry. The nasal spray version, S-ketamine, it's called Spravato. It is FDA approved. And I was part of those clinical research trials to help it get FDA approved. Here's the problem though. Anything that's brand new, well, it's not brand new. Now it's been around for 4 or 5 years. But it's still patented, right? It's not generic, meaning only one company has the patent, which is Johnson & Johnson, right? Insurance companies, let's be real. Insurance companies aren't in the business of spending money, right? So they're going to do everything they can to deny you approval to have this approved. So you will, trust me when I say, you will have to jump through hoops to get nasal spray as ketamine approved. They're probably going to say you need to do cognitive behavioral therapy. You probably have to try 2, 3, 4 different antidepressants first, meaning SSRIs, SNRIs, then we might approve some ketamine treatments, okay? But at least there's a pathway to get it potentially approved by your insurance. So that is the main difference between the two. IV ketamine is going to kick in faster, go straight into your vein. Can't beat that, okay? You're probably going to need less treatments over the course of the acute course of treatment. Nasal spray, at least there's a pathway it can get covered by insurance. You're going to have to jump through a lot of hoops, but at least there's a chance it can. That's the biggest difference between the two, okay? Lastly, and then we'll pause and answer some questions, okay? There is a time hassle with ketamine, okay? Whether you're doing IV, whether you're doing the nasal spray, you have to go to a clinic, and after your dose, you will be monitored for about 2 hours. Okay, if you're doing nasal spray, you're doing 2 hours, 2 visits a week for 4 weeks. So can you afford to commute to that clinic, back and forth, be there in the waiting room for a little bit, get your nasal spray or the IV, and wait there for an additional 2 hours and have someone drive you back home? And can you do that while missing work, right? That's going to be the problem, right? Time commitment. So again, 2 hours of post-dose monitoring every time you get a dose. Okay, twice a week for 4 weeks for the nasal spray. IV, it's a little bit variable. You might do it twice a week for like 3 weeks. You might do it 3 times a week. So it depends on the IV clinic. But it's going to be a time commitment. Why do you need to do that? Because of the side effects, okay? Sedation. You might feel pretty groggy afterwards. Dissociation, okay? Even though we're not using the same doses that we'd use with street abuse, we're not using the same doses as an anesthesiologist would, you can still dissociate. So for those of you who are not familiar, you can have sensory changes. Colors can seem more vivid, lights can seem brighter, dimmer, sounds, and your experience of it can differ. Your sensorium is altered. You can feel like you're having depersonalization or derealization. You feel kind of goofy or high, for lack of a better term. So that plus the sedation, blood pressure changes. You can get an increase in blood pressure, in particular in the first couple hours. Nausea can happen. Those are some of the more common ones, but especially because of the sedation and drowsiness, the dissociation, most of those things last for a few hours. That's why they have you stay for 2 hours after the fact. Okay, that's a hassle. Okay, but some people say that it's life-changing and it's something that helped when other standard SSRIs have not helped, that it's worth it to them to go through that and then hopefully have to go less often for some like intermediate maintenance treatments. Okay, but those are the logistical hassles and the cost and accessibility hassles of ketamine interventions. And they're slightly different depending on if it's IV or nasal spray. Let's take a pause, and then we'll get into some interesting quirks about ketamine and some offshoots of it. So a couple comments here. Chris, if you're still around on the chat, thank you for joining. Chris says, have been using IV ketamine in clinical environment for 4 years for PTSD. Has been life-changing. It is not, as you said, a cure-all. Exactly. See, you heard me. I'm not trying to oversell ketamine, but it has been the most effective pharmaceutical I've experienced. Look, interesting. Yeah, definitely. I mean, again, it doesn't have the FDA approval for it, but IV ketamine's been used for several things, right? Again, keywords, guys, off-label, right? So I'm not promoting this, but off-label, it has been used in PTSD. It's been used off-label even for sometimes been bipolar disorder, etc. So no, that's very interesting. If you have any other pertinent experiences or anecdotes with it, please share with the chat. So, Andrea, thank you, Andrea, if you're still here on the chat. How does Chanics fit into all this? Well, Chanics, I don't believe Chanics really has much evidence of having antidepressant effects. If anything, there's some concern that Chanics can induce depression. Now, I will say one thing, though, Andrea, so stick around. If you could stick around even for 5 minutes, I'm going to get around to it. Wellbutrin, or buproprion, which is also used for smoking cessation. It's an antidepressant, but it's also FDA approved for smoking cessation. There is a role for that related to ketamine, okay? I'm going to talk to you. It's a very interesting quirk, so I want to mention it so that, again, increase your knowledge base and awareness, all right? So we'll talk about that in 1 minute if you hang around. So it's kind of at least loosely related to your Chanics question. Carrie says, Carrie is a regular listener here. How does esketamine, glutamate, BDNF paradigm compare to SNRIs? Well, that's a broad question, so I'm not sure exactly what you want me to comment on there, but I would say esketamine, ketamine, anything that's glutamate based or BDNF, it's really exciting. It's basically opened our minds to just say that we call it, the nerdy term is monoamine. So serotonin, norepinephrine, dopamine, those are called monoamine. So the monoamine hypothesis that's been around for over half a century now, we realize that is no longer the end all be all. Okay, so if anything, even though ketamine and esketamine are not perfect interventions by any means, okay, what it has opened up our eyes to, meaning it is a radical direction we've gone as a field in the field of psychiatry, is that we just said, oh my God, there's this whole nother dimension of treatments that we have to explore. And we realized that the monoamine hypothesis of serotonin and norepinephrine and dopamine, it really only explains a small piece of the puzzle. We used to say that was the end all be all, right? And it's only going to explain a percentage of the puzzle, and that's why it makes sense. Here, so really quickly, again, people are going to find stats that refute what I'm saying, but I'm going to say as a general rule of thumb, people who have major depressive disorder, aka the most common subtype of clinical depression, on your first go around with an SSRI, you're only going to achieve marginal rates of remission. That's a sobering fact, meaning about 1/3 of people will achieve remission. Remission means basically you're back to your baseline, okay, meaning you feel like your clinical depression is resolved. 1/3, meaning 2/3 of folks do not achieve remission. I would say over half get a positive response. Positive response doesn't mean remission. Positive response means your severity of symptoms have reduced by 50%, meaning you still got plenty of work to do, okay? But remission rates are about 1/3. So if the monoamine hypothesis is the end all be all, why does that leave 2/3 of people not getting remission, not achieving remission? So meaning there's got to be more to this, right? So glutamate, BDNF have opened our eyes to a whole nother subset of treatments. And also that paved the road, that trailblazed the road for all of the psychedelics that are in the pipeline. Okay? Meaning psilocybin, MDMA, right? LSD, all these things, they wouldn't even be in the pipeline or this close to FDA approval if ketamine and IV ketamine hadn't paved the way. All right. So, and then another question before we move on. So let's see. Carrie also says, so would you say SSRIs are first generations, SNRIs are second generation, and ketamine is third generation, with each generation explicitly better than the last? No, I wouldn't say that. So here's how I would say it. I would say, fascinatingly enough, tricyclic antidepressants, TCAs, tricyclic antidepressants, those existed, and there were also other ones called MAOIs, MAO inhibitors, or MAOIs. Those existed before the SSRIs of the 1980s, meaning fluoxetine, Zoloft, Prozac, etc. So the original tricyclic antidepressants, those were actually both SSRIs and SNRIs. So SNRIs, the SNRIs actually were widely used and predate SSRIs, if anything. So there's also this misconception out there. So those are actually kind of the original generation of the massively commercialized antidepressants. Then Prozac or fluoxetine and fluvoxamine or Luvox, Zoloft, which is sertraline, those are almost the second generation that were the cleaner SSRIs. Cleaner just means they really primarily focus on serotonin. Then interestingly, in the 90s, SNRIs made a comeback. Duloxetine, which is Cymbalta, venlafaxine, which is Effexor, and now there's several others. And it was interesting because society and even physicians, like lay public physicians, were like, oh my God, we got SNRIs. And most pharmacologists who are savvy are like, what are you talking about? We've had SNRIs. They're called tricyclic antidepressants. And they've existed since the 50s, 60s, 70s. So the main difference with the 1990s generation of SNRIs were that they were a little bit, I don't want to say a lot, but a little safer in overdose scenarios in terms of cardiac toxicity. Okay. So I would kind of lump SSRIs, SNRIs just kind of as like generation one. And I would say, yeah, I think that's appropriate to say glutamate modulating. I would actually throw in two different things, glutamate and GABA. Glutamate and GABA, GABA, GABA modulating drugs is like Gen 2. And then potentially we might see psychedelics coming out as like Gen 3, okay? I wouldn't necessarily say each gen is better than the other. So that's my only other comment before we dive into the next segment of our talk today, okay? Wouldn't say that they're necessarily better. They're different, and different cohorts of people might respond better to one group versus the other. I know that's generic, but I think that's true. Until someone does a massive scale head-to-head study, I think it's really hard to say. That would be an overreach to say, one group is better than the other per se. I think it's really we're gonna find that this is such a heterogeneous problem. We have to get better at figuring out what cohorts of people respond better to one category versus another category. Okay. All right, let's get back on track. I know we're already getting close to, we're already close to the hour. We're just blabbing today. So this is a fun topic. So So we might have to get around to the MDMA and other stuff later, but let's keep talking about ketamine. So here are some interesting offshoots, and I want to hear your thoughts about this, okay? So I just went through about how, on one hand, it's exciting, right? We have new stuff for the first time in several years. We have ketamine-based interventions that are not your standard fare SSRIs. But I kind of gave you the downer, right? That cost and accessibility are going to be a problem. And it still remains true to this day, unless you got a bunch of cash laying around for IV ketamine, or unless you have really good insurance and you and your doctor are really fighting insurance ridiculously at lengths to get it approved for the nasal spray, it is tough to access this stuff, right? So what are people doing as like workarounds, right? What are some interesting workarounds? And I'm not even promoting these. I'm just saying these are interesting workarounds. And one of them is reasonable. One of them gives me a little pause. Okay. So let's do the reasonable one first, and then we can blab a little bit more about the one that gives me a little pause. So there is another drug out there that has been recently approved. It is called, I believe I'm pronouncing it right, Auvelity. Okay, Auvelity. And interestingly enough, if you dig, it doesn't take much digging, but if you actually read the ingredients of Auvelity, it is a combination pill that contains bupropion, which is Wellbutrin, which has been around for decades, which is an FDA-approved antidepressant, Wellbutrin, and the key ingredient is dextromethorphan. For those of you who bother reading the boxes of your over-the-counters, I see a bunch of you still on the chat here. You might say, what the hell? Isn't dextromethorphan a cough suppressant? And the answer is, yeah, it is. And it is something that is in your over-the-counter medication. So we have a company out there who decided to combine an over-the-counter cough suppressant with I don't even know at this point. They might put it behind the shelves at this point, or the pharmacy part. But they combined a cough suppressant, dextromethorphan, with Wellbutrin. Why? So this is the fascinating science behind this, guys. So they said to themselves, well, we see the writing on the wall. We are not first to market. There's other companies that already have ketamine offshoots, right? They're like, let's do something where people could do it at the convenience of their home with a regular prescription, rather than having to go to a clinic and do that 2-hour post-dose monitoring that I described, right? So why would they repackage Wellbutrin or Buproprion? Here's the thing. It's a weird concept, but they are trying to purposely, keywords, purposely cause a drug-drug interaction. They want the drug-drug interaction to occur, okay? So when you take Wellbutrin or Buproprion, an FDA-approved antidepressant, and you mix it with dextromethorphan that's already in the tablet of Auvelity, what you're doing is the following. Their Buproprion will slow down the enzymes that digest dextromethorphan. And what that will do is, rather than dextromethorphan going like this, spiking and dipping rapidly, it will sustain dextromethorphan at a tonically high level and just keep dextromethorphan at a high level. And when you sustain dextromethorphan at a sustained high level, it will modulate glutamate. It will interact with what are called N as in Nancy, M as in Mary, NMDA receptors. And by modulating NMDA receptors, when it's stuck at a tonically high level, it will modulate glutamate transmission. It's not going to be as potent as straight up giving you IV ketamine in your vein or ketamine variations in your nose, but they're essentially trying to almost mimic at a very mild level what other glutamate modulators do. So fascinatingly, they are leveraging a drug-drug interaction to their advantage to sustain dextromethorphan at a high level to then finally, ever so slightly, induce glutamate modulation. Interesting workaround where you can try a novel mechanism by using a drug-drug interaction, using science to your advantage. Fascinating. Fascinating. So that's one way people are trying to test out kind of a different approach than standard SSRIs without having to necessarily go to a ketamine clinic. So just figured that I'd mention that because it's very fascinating, probably not well known, and probably not enough people talk about it or break it down, to make it easily digestible to the lay public about what the hell the combination of those two things are doing. A lot of patients of mine are like, why am I just taking repackaged Wellbutrin or bupropion? I try to explain to them what I just explained right now. So lastly, another workaround, I have qualms about this one. There are companies out there that will basically send a nurse or a physician, a medical assistant, I would say medical assistant or nurse to your home, your house, your apartment, and they will bring you a ketamine lozenge. Have you take the ketamine lozenge at home, have a doctor or a nurse practitioner pop up on telehealth to probably talk to you for a couple minutes, and then have that nurse or medical assistant monitor your vitals and just make sure you're not totally getting loopy with dissociation, and monitoring you at home. I'm not going to name companies. I don't want people coming after me for no reason. What do you think about that? You say, hey, I'm all for it because it improves my ability to access this. Even if the monitoring is looser, it's not really being done with closer supervision at a clinic. I'm responsible enough as an adult if that improves my access. So if it improves access, then that's for me. Okay. I'm sorry, guys. I have to read this one. KG10 says, nurse delivering ketamine lozenge equals K dash. You know what? KG. You think you know what? You probably yours sounds better than the names of these other companies. Like we need to go into business together. We need to ketamine dash K dash. Just order it on your app, and we'll drop off ketamine at your clinic. So, Frankie the Blue, thank you, Frankie. Frankie's joined us before. Does it make you relax or something? Well, it depends. Again, some people who take IV ketamine lozenges, ketamine nasal spray, some people will get groggy and sleepy, just flat out take a nap. Other people will say it has a calming effect. Some people feel like they get high, or, even if they haven't done illicit drugs in the past, they'll say, I just feel out of it or high. Some people will flat out dissociate. Some people will get giddy. Others will get anxious and have a panic attack. So you're going to have a wide spectrum of people's responses. So one can't assume how someone's going to react post-dose from ketamine, but you could get a relaxing experience. So Chris also chimes in, I think coming out of the home to get the clinic experience is better because there are not the triggers present in the clinical environment. Yeah, I agree with that, Chris. I think my main concern is I've had firsthand experience administering this to patients in clinic, meaning ketamine, that I just know that some people do get pretty bad side effects, right? Some people do get big blood pressure spikes, right? And you might need to administer some emergency antihypertensive medication. Some people are so out of it, you wonder if you need to actually send them to the ER because they're so sedated. They're not even waking up when you're rubbing their sternum and doing a sternal rub. So just things can happen. And, some of these companies, to me, yeah, of course, they are always going to sit on their high horse and say this is for access for the people. But it's about making money. It's about cash, right? So, anyways, I wanted to bring that up. That's another methodology that people are doing it. I mean, people are literally getting ketamine delivered to their home with someone stopping by, having you pop that lozenge in your mouth and observing you. I mean, look, I've had some patients who say they felt better. And again, I don't disbelieve the science behind it. I do think there's going to be higher variability and less predictability of absorption when you take ketamine as a lozenge. And that's just fact. That's not opinion. That's science. when you take it as a lozenge versus putting it straight in your vein or taking it through the nasal membranes, you're actually not going to get as predictable and as consistent of absorption and blood levels. It's just not. But so that's one concern, is just an objective concern about bioavailability. The second is just the safety component that concerns me. It's not like I'm saying it's impossible. It's just, I know how healthcare works, and I know how money making and profiteering in healthcare works. And I don't know that safety is the priority of folks who are doing something like this. So, it's just a concern of mine. So, okay, let's move on. It was a pretty interesting topic, but if you have more questions about the ketamine, keep them coming through. Let's talk. I'm trying to make a judgment call here. We might table the TMS. Well, I'll take a vote. You guys are here. So the 15 of you that are chatting here, you guys, I'm going to leave it up to you because we're already at the hour mark, but this is exciting. This is a lively conversation. I'm going to stay on for another 15, 20 minutes here. We're going to have to cut this short and probably do part 2. I'm going to give you guys a vote. We'll vote for 30 seconds, and whatever I see the most of, we'll talk about. I'm going to give you the options of what we're going to be able to cover today. We can stay on this kind of ketamine theme, and we could talk about another variation of treatment that focuses on the opposite chemical system that I just talked about. It focuses on the GABA system, GABA, and these are treatments that are FDA approved for postpartum depression that are novel and kind of interesting, and obviously are also being looked into for regular kind of plain old non-postpartum depression. We can go that route for 15 minutes. We could talk about TMS, Transcranial Magnetic Stimulation, for those of you who are not familiar with that and want to learn a little bit more about that. Or we could talk about Psilocybin and the recently failed MDMA trial for PTSD. So do we do psychedelics? There's 3 choices: psychedelics, TMS, or the GABA drugs, GABA drugs for postpartum depression. That's also kind of a new breakthrough. So which route are we going for tonight, guys? Because we're not going to be able to get around to all 3 topics because I blab. I'm a talker. So I'm going to give it 30 seconds, and then we'll go. So Starry says TMS. We got 1 vote for TMS. Going to give it 25 more seconds. 1-0 right now. Psychedelics from Carrie. So Carrie says psychedelics. Starry says TMS. 15 more seconds. It's tied 1-1. So who else? There's 16 concurrent. We got Andy says psychedelics. Andy, thanks for joining. Andy says psychedelics. Chris says psychedelics. Teresa says psychedelics. Give it 5 more seconds. Going once, going twice, or else it's going to be a runaway train with the psychedelics. We got Teresa, Chris, Andy, Carrie, Frankie. Okay, all right, guys. I'm going to go with the people. Let's skip over to psychedelics. We can table TMS and GABA for another talk. Okay. So let's talk. Let's first, KG, I'm psyched for the delics. All right, psychedelics won by a landslide, so we're going to give what the people want. So first, let's talk about psilocybin. All right, or AKA, as most people know, it's shrooms or microdosing with shrooms, right? But the active component, right, is psilocybin. All right, or some people say psilocybin, but let's just say that. So basically, real brief, not to get overly nerdy and in the minutiae. Again, what makes this unique, right? What makes it different than the standard SSRI, right? So the theory is a lot of this is actually based off other chemicals, right? That we learn from ayahuasca, right? Ayahuasca potently affects a very specific subtype of serotonin receptor called. So whenever you hear this term, and someone said it earlier when it comes to supplements, 5-HT, right? 5-HT is essentially the nerdy way of saying serotonin, okay? So ayahuasca potently affects 5-HT2, the number 2, and then the letter A, 5-HT2A receptors, okay? And these receptors tend to become overrepresented and overactive during clinical depression. And based off the effects of that, that spurred on a lot more research in the psilocybin realm. And basically, this is an oversimplification. The hypothesis is that using psilocybin can briefly disrupt neuronal connections and disrupt kind of the set point of these 5-HT2A receptors, okay? And allows the brain a chance to reform new connections, basically try to restore a healthier balance in the following days and weeks following a single dose of psilocybin. Okay? So what a few companies are doing right now, and they're pretty close. I'm going to tell you right now, they're pretty far along the clinical trial pipeline. And my relationship to this is, I was not a principal investigator running a clinical research site using psilocybin, but I was loosely involved, where I have worked as what's called a blinded rater. Okay? Meaning to try their best to get rid of bias at the clinical research center site. Okay? They would literally call me to then perform an interview and assess someone's level of depression after their dosing. Because I don't work for the research center. I don't know who got the real drug versus the placebo. I have no skin in the game. I'm not going to make extra money whether this person has a good response or not. My job is to just independently assess folks, right? But I'm going to say it's kind of hard to blind. For those of you who aren't familiar with research, right? When you do a well-conducted study, right? One group gets the actual experimental treatment, the other group gets a placebo, right? And for most like pills and tablets that they test, people don't know what to expect, right? So they're hoping that they're taking an experimental drug that doesn't have many side effects, right? So most people tend to not know what group they're in. But when it comes to psychedelics, it is hard to blind or trick people into what group they're in, right? So even with me being a blinded rater, it's not hard to kind of guess what group someone was in, right? Unless someone is so naive to what it feels like to have ever taken any kind of drug, I think most patients can assume and figure out whether they're in the group getting the psilocybin or not, right? So, but my loose association with this is, at least there's many studies, so I'm not giving away anything or breaking an NDA. At least for one of the particular studies, I got to be a blinded rater where I got to assess people after their dose. It was fascinating. It was a very fascinating experience. So a couple companies are going about it in a couple different ways. All right. A couple of them are going very heavy on trying to get this approved, combined with very specific therapy interventions, meaning they want to get like a protocol approved. So it's not just about giving a single dose of psilocybin, it's about giving it along with a very structured set of therapy interventions along the way, where there are some studies where there's very minimal therapy interventions and it's really more reliant on just the actual chemical effects of psilocybin. So why is that important? We'll get to it later, related to the MDMA failed trial, okay? But I would say more traditionally, more people are doing a protocol where it's called preparation, dosing, and integration sessions, okay? So let's talk about what that looks like, okay? So there's been many years already of studies with psilocybin. So what most people in psychiatric research agree upon now is that at the very least, even before this gets FDA approved, I don't think this is an overstatement. At the very least, for a percentage of patients, this seems to be a promising, at the very least, short-term intervention for treatment-resistant depression. Okay? Because we didn't get to the point of being close to FDA approval, meaning you have to go through several phases, phase 1, phase 2, phase 3. And they're at the phase 3 point where there's gonna be a decision at some point within the next year or so, probably. Without having some foundational research. And we have enough research to show that there will be a percentage of patients whose depression will dramatically improve within 1.5 weeks of taking their dose. That's the time frame of response that tends to happen. The question really becomes durability and how long does that improvement sustain after that first dose or microdose of psilocybin. That's where the debate really is, okay? How durable is the effect? You can go look it up. Trust me, you can go look it up right now. There are going to be some studies that say, hey, the durability seems to last for several months, 3 months, right? Then you have one study that's an outlier that says, oh, like we have a cohort of people who sustain their improvement even after a year. Then you have other studies that say, hey, durability of effect didn't seem to last more than 2 months. So you're going to find some conflicting data out there. So that's really the question mark. I actually think there's enough data. I would be shocked if, just from a pure efficacy standpoint, that this doesn't get approved at some point in the future, at least for short-term intervention, for short-term improvement when depression gets really bad and standard treatments are not working, okay? That part, I don't really have much doubt. I would be shocked if that didn't happen. But I think the question is going to become safety, and does it make sense for those to do maintenance doses? Do you need like a refresher dose 6 months later, 1 year later? Like, what does that look like, right? And it's really a question mark about the intermediate to long term and the durability of effect, in my opinion. Okay. So let's talk about what happens, right? So I use those terms: preparation, dosing, integration. Okay, let's talk about that a little bit so people understand what's being researched right now. Typically, this dosing is done with a protocol of therapy. Okay, and in the early stages, obviously there's getting to know the patient with a therapist. There's a therapist who tries to understand patient's personality style, their history, their traumas, their history of depression, their attitude about what they're going to experience with their psychedelic experience, what their fears are about the psychedelic experience, what their hopes are for the psychedelic experience, because they may need to integrate some of that into the dosing session and the post-dose sessions. Okay, so that part is crucial. And that also makes it complex because that introduces so many variables, because there may be some patient variability, right? And therapist variability and skill set, right? So we're not just saying in a lot of these trials, it's just, here's the dose, good luck. There's this preparatory therapy that happens prior to the dosing, okay? Now, after one has gone through the preparation phase, I said dosing, you actually get your dose, okay? And you are monitored for approximately 6 to 8 hours after your dose. I know that sounds long as hell, but that is what is happening in these research studies. And if it gets FDA approved, that is what's going to need to happen. Kind of like what I said with ketamine and the 2-hour post-dose monitoring. Probably going to need to be monitored. I don't know what the exact time frame will be if it does get approved, but it's going to be pretty long. Okay. And right now, a lot of the trials, some of them are testing out 4-hour post-dose monitoring, but a lot of them are still around 6 hours of post-dose monitoring. Okay. Because of the effects and how long they take to wear off, side effects to wear off, etc. And during that session, you are being continuously supervised by at least one therapist. And that therapist is encouraging you to focus your attention inward, doing introspection, focusing on the psychedelic experience itself, maybe guiding you back to a more grounded state if anxiety is coming up, trying to maybe bring up some of those themes and topics that you had wanted to explore, during that preparatory phase I mentioned. So you literally have someone with you during the entirety of that multi-hour dosing session. Okay. And then integration, the third term I used, we said prep, dosing, integration, right? You will have at least one, but some protocols have multiple integration sessions where you work together with that therapist to interpret meanings developing insights from that psychedelic experience. And why? We are trying to meld biology with the psychology of that psychedelic journey. Because here's the fascinating part, right? This is the crossroads of psychology and biology. I said giving you that single dose of psilocybin can disrupt connections in your brain. And you are forming new neuronal connections and reshaping and resetting the set points of receptor density in those following days after your dose. So there is a belief that this is the opportunity to, now more metaphorically speaking, decondition malformed cognitions, cognitive distortions, cognitive self-deprecation, all these things that you have conditioned yourself to believe in maladaptive ways. This is the opportunity to change those things from a psychological perspective while biology is also changing. Now, here's the last thing, okay? So Andy says, oh, Frank, thank you for that super badge thing. I appreciate that. You didn't have to do that, Frank. I appreciate you, though. Thank you. Frankie sent me some super badge applause stuff, so I appreciate that. So Andy says, one experience with psilocybin did more for my depression than 15 years of different antidepressants. Wow. You could keep chatting. Let us share with the group what you went through, Andy. I mean, I appreciate your commentary, so let the group know as I keep blabbing here for another minute. So here's something that's fascinating, right? I mean, some people might say, "Oh, you sound like a voodoo shaman talking about reforming connections and all this." No, look, go type up right now. Not that everything you type up on the internet's true, but go type up psilocybin and type up fMRI, functional MRI, fMRI. Okay. And trust me, you will find hundreds and hundreds of papers. Functional MRIs are real-time MRIs, right, that try to show you neuronal activity while you're awake and while you're doing certain tasks, okay? I mean, that's oversimplification, but I'm going to do a butcher job on this. If you ever want, you should go talk to people at Brigham and Women's Hospital in Boston. They're the people you want to talk to about this stuff, okay? But essentially, the theory here is, and what they've shown on fMRI imaging, is that we have certain pathways that light up. Even when we're thinking about certain memories, thinking about how to tackle a certain task, thinking about, conditioned patterns of thoughts, thinking about our routines, like they can map out how your brain functions, at least the patterns, right? Interestingly enough, we've seen that with the use of psychedelics, you can literally basically deconstruct and melt away the preconditioned pathways that existed before, meaning after your dose of a psychedelic, right, the pictures and the pathways of how your thought processes approach the same topics that we just talked about are going to look different pre and post, meaning we can actually visualize, right, conditioned patterns of thought getting altered after a single dose of psychedelics with some of this intra-psychedelic trip therapy / post-integration therapy. We can image it at this point. That's insane. Okay, and again, I did a horrible job of explaining this, but all I'm saying is, if you want to understand more of the kind of more exciting cutting edge stuff about this, go look up fMRI. Well, look at what Andy's saying. So look at what Andy's saying. I know, and again, for people who are going to criticize me, I know talking to one viewer here, but all I'm saying is, right, these anecdotal experiences are what fMRI imaging is showing sometimes, is that Andy's saying it felt like my brain was rinsed, basically had like a reboot or a reset or something, and music signals almost like defragging your hard drive. I mean, so Lisa, oh, thanks for Lisa from Seattle's joining us. Lisa says, "I'm jumping in late. Would it help with healing trauma?" Well, interestingly, yeah, that is an area right now. I would say closest to the finish line, Lisa, for psilocybin, and in terms of clinical indications, is for major depressive disorder, clinical depression. But hot on the trail, they are looking at it for trauma. Okay. They are looking into, so PTSD and trauma is definitely the other area that they're really looking into right now. They're really looking into. So, and we'll talk about trauma, Lisa, in 1 second. We'll talk about MDMA and the trial that failed for that. But yeah, so what I just described, probably the closest to the finish line right now, where the FDA is going to make a judgment soon, is about depression. But yeah, PTSD and trauma is the other hot area where psychedelics are being looked at, including psilocybin. Okay, so and you can see what I just described, that whole process, right? The preparation, the psychedelic trip session, the integration session. It is ripe for rewiring our connections and our associations, both physically, emotionally, with traumatic experiences, right? So it is pretty exciting, right? Now I want to also, again, tempered expectations. I just hope that, if it does reach the point of being FDA approved, that it's rolled out to the public safely, that appropriate monitoring protocols are in place, that this is not oversold. Am I being a downer? No, I'm not being a downer. Trust me. Again, for those of you who live in metropolitan areas and listen to the radio, you heard my comment about ketamine, right? How many ketamine clinics advertise on your local radio station? Come to Dr. So-and-so and get your ketamine injection. It'll be a treatment for your OCD and PTSD, and we'll use ketamine to stamp out your alcoholism. I kid you not. They're saying they're going to give you ketamine to just stamp out your heroin addiction, your alcohol addiction. Give me an effing break. Okay? Ketamine is not a cure-all for everything. So what did I say? I said, I did ketamine research. I've worked on Johnson & Johnson Speakers Bureau. I'm giving you fair and balanced here, guys. Okay? Trust me when I say, when there's money to be made, vultures, predators will be out there, right? And that's my worry, is that again, we shouldn't stop science from advancing because of predatory concerns. I'm just saying you got to look out for yourselves, right? That even if it does roll out and psilocybin gets FDA approved, just be careful, right? Just be careful. Because you will find physicians out there who will milk it and do predatory stuff, right? Again, I don't even want to get into it because I'm going to get sued probably. But look, trust me, there's clinics out there right now who promise you precise diagnosis with pretty pictures out there, right? Say they're cutting edge, and the rest of the psych field is they're scam artists. They're just doing trial and error with their drugs. Come to our clinic. We'll give you some pretty pictures and tell you your exact diagnosis. Oh, by the way, we didn't tell you. It's going to cost you $5,000 for those pretty pictures, right? Trust me. There's predators everywhere, guys. So it doesn't take much of a Google search. You'll know who I'm talking about, right? So we just need to be guarded. So let's talk next, right? So that's exciting stuff. That's the exciting stuff with psilocybin. But let's sobering, right? Sobering and balanced. MDMA, right? Better known by the public, right, as ecstasy when it's used as a street drug, but MDMA used for medicinal purposes. That was also supposed to be the next guarantee slam dunk, right? And so this is just a sobering reality check for those who are Music's 13. Music says, you did a piece a year ago on delirium tremens. I was an alcoholic for 15 years, and that video really helped me understand the disorder. I had my psychologist and GP agreed to administer a single dose of psilocybin, and it changed my life. Have been clean ever since. Thank you, by the way. Music. Hey, I know we're strangers. I'm I'm happy for you. I don't even know how to say it. I'm so happy for you. I'm so happy for you. You made my weekend. I Without hyperbole, you made my weekend. Me putting out a random educational video into the ether of social media and the internet, I mean, it really makes my day. Really makes my day. I mean, even like I'm not taking credit. You have all, you take the credit. You have all the credit for, you were motivated, you sought help, you did something about it, you've stayed motivated to stay sober. Everyone here needs to give applause to Musics right now. Everyone needs to pause. From Australia, of all places, everyone pause. Please send good vibrations and good vibes and just really happy thoughts and congratulations, and just send more motivating thoughts to Musics, because Musics will be the first to tell you that it's a fight and it's a battle. But look, you're oh God, Musics, look what you're doing to me. Like, not to sound cheesy and corny, like you're getting my eyes to well up. So that's Musics, you know. I'm going to just be corny. This is why I like being a physician. I hate most of healthcare. I hate the administration. I hate our healthcare system. I hate paperwork. I hate insurance companies. I hate all the nonsense that makes me do. Probably 75% of what I do is non-clinical because of all the paperwork we have to do. But hearing stuff like that, this reminds me, like, why the hell I even bothered, getting into medical school, is just when I get to see people, make healthy choices for themselves. So Musics, just really, really, our hearts go out to you. And look, people just sending you, I know we're all strangers here, but, I just that's really great, Musics. I mean, you're making my eyes well up. So just really happy for you. So yeah, no, it's, so psilocybin is exciting. Now here's some sobering realities, right? Reality check. MDMA, it was voted on in August, I believe. I could be off. It was July or August of 2024. And the FDA voted, I think I could be a little off. I think it was a unanimous 10-1 to reject protocol for MDMA dosing for post-traumatic stress disorder, or PTSD. And it was a big blow to kind of the psychedelic hype train that was coming through. And basically they said that, the data was very biased, that it was challenging to take out a lot of the confounders and bias in the data. And look, this is the comment I made. It's very challenging to blind a study when it comes to psychedelics, right? In a traditional study, like I said, placebo, experimental drug, oftentimes, most of the times, the treatment center, the doctors, the nurses, the therapists don't know who's on what, right? Patients don't know who's on what. And you just kind of approach the treatment as unbiased as possible, and you try not to get too excited one way or the other about people's comments. And here's the crazy thing. People say, well, how can that be true? Here's the crazy part. If you want to hear statistics, guys, in clinical depression research studies, the rates of remission, I'm not saying get slightly better. I'm saying your depression is gone. The rates of remission for a placebo group in a traditional clinical trial in the past decade, the average remission rate is about 30%. 1 out of 3 people who enter a clinical research study and who get a fake capsule, a capsule that contains inert chemicals, nothing, by the end of that clinical study, their depression is gone. What does that tell you? That tells you that's, number one, how difficult it is to run a clinical research study and control for the placebo response. But number two, I'm going to actually put a positive spin on this, guys. It shows you how powerful mindset is. It shows you how just damn powerful mindset and hope can be. People who have been depressed for months, for years, for decades, entered clinical trials, and by the end, even though later you find out, sometimes you find out 1 year later that they weren't on the experimental drug. They were on nothing, but their depression got better because they believed that they were getting help. They believed that there was hope. They believe that this is going to work for them. And that has a spillover effect to influence your behavior and your attitude and how you viewed life, right? So if there's any silver lining to take from that comment, I know we went on a tangent here, is God, that is why, as cheesy as psychiatrists and psychologists and therapists sound, this is why we harp so much on why mindset is so important. That is evidence. That is pure evidence how powerful mindset is. People always view that as like, oh my God, this sucks. Yeah, it does. From an experiment standpoint, it sucks that we have such high rates of placebo response, but it also demonstrates that mindset and therapy is so crucial. Okay, but anyways, the old double-blind tic-tac placebo trial. So, musics. So, but now let's get into psychedelics. It's just so hard, right? Because unless you are so naive and you've never been under the influence of anything, I don't mean that in a pejorative way. I'm just saying it is pretty obvious when you consume or ingest MDMA or ketamine or psilocybin if you are on the drug or not. So there is almost no way to blind this. I'm sorry, there really just isn't, okay? So that introduced a lot of bias, obviously. It was also complicated because the MDMA trial was a little bit different than some of the psilocybin trials where they were trying experimental therapy approaches. And that was a crucial component too. They wanted the therapy slash MDMA combo to be the approved treatment protocol versus just kind of focusing on MDMA itself being the intervention with support from therapy. So I know that was kind of nuanced, but if that makes sense, right? But it's rather than just saying we want MDMA with some support, with therapy to support it to be approved, they're like, we want this specific protocol, the drug plus this kind of experimental therapy intervention combined to be approved. And I think that was kind of a mistake, honestly. And sometimes protocols can doom themselves from the beginning when they're designed poorly. And I think it was a mistake to get that nuanced and do it that way versus just simply saying, like, let's just bank on the drug having a chemical effect. And, we'll be there for some monitoring, some supportive psychotherapy to help them calm down if they're getting panicked during the session. But it was a little bit more specific than that. And it was kind of like a double package. And, I'm not going to say that this, I'm not going to say this company itself is the problem, but there is a concern I have with kind of the psychedelic advocacy groups, some of them. There's a couple of associations out there. How do I put it? There's I believe there's self-serving interests involved in some of their lobbying, right? For people to become certified for psychedelic assisted psychotherapy, good Lord, go Google that, guys. Go Google that. All right. Type in, where do I go to become officially certified as a psychedelic assisted therapist? Right? Go Google it and tell me, how much does it cost? Tell me how much it costs. Someone, while you're on the internet, you're on your phone, you're on a website, instead of hearing clacking come on my microphone, go Google it. Say, cost to become a psychedelic assisted there. You're going to find that it's probably somewhere in Arizona, in Utah. It's always one of these Southwest states where they have some of the biggest lobbyists and people who are pushing this stuff, right? I'm not saying it's a bad thing, but they charge absurd. I mean, it's a cash cow. They're like, come for this weekend retreat. We're going to do a bunch of, mindfulness exercises. We're going to train you as experts in psychedelic assisted therapy. And by the way, it's several thousands of dollars, and you'll get this nice little piece of paper certificate saying you're now officially certified by us. And so rather than just kind of focusing on some of these chemicals going through, they also want to patent. They want to patent, and stake their claim to fame and become a trailblazer in the history books of mental health that no one's ever going to read. That they patented, this specific therapy style, and they were the first experts to do it. And they want to be the only people who want to certify people who are allowed to call themselves psychedelic assisted therapists, right? I mean, so it's just, again, guys, it's so sad. My comment is money. When money is involved, money, fame, pride, it sometimes even gets in the way of science. But anyways, I went on a tangent there, but all I'm saying is I want there to be new treatments for depression, right? I'm excited for some of these things like psilocybin, but I also think MDMA, the failed trial for PTSD, was a sobering wake-up call, right? Because if you asked the industry and all the lobbyists out there, and trust me, the psychedelic lobby group is... Trust me when I say the psychedelic lobbying group is not a grassroots lobbying group, okay? You have investment capital, big pharma, startups. You have tons of people backing the psychedelic group. People are waiting on pins and needles for the first wave of psychedelics to get approved. You don't think someday, 5 to 10 years from now, just like you're seeing dispensaries pop up everywhere with marijuana, you don't think you're going to have your local psilocybin dispensary? You don't think you're going to have your local microdosing clinic for MDMA for psilocybin? Oh, trust me, guys, it's coming. It's coming. We're headed that way. So trust me when I say, people view pharma as the bad guy, as Darth Vader and the Empire, and the psychedelics as like the grassroots little guy. Don't be fooled, okay? I'm not saying let's not be excited about psychedelics. I'm just saying... oh yeah, so music's, you're right. Says massive pharma groups are even taking over local farmers for marijuana. That's what I'm saying, right? So I'm just saying, what started off as kind of this like grassroots industry, just later on, right? Follow the money trail, right? Who's funding all these lobbyists, right? Trust me when I say it's not coming from pure altruism, right? There's profiteering that's happening. There's money to be made. And this is why even the psychedelic group has just become they have a strong lobby group at this point, right? So we have to be tempered. I want some of these things to come through. I want more treatments available for patients. Some of you have already even tried them, as like Andy said, as Music said. So it's just, we got to do it the right way. We got to do it the safe way. So I get torn because, look, I know that our government and pharma and the FDA slow things down. I know that our healthcare system is so broken. We do need to be a little bit disruptive, as some of you here have done, have taken matters into your own hands. I don't blame you. You got to do what you got to do to survive. I get it. I get it. So how do we find a middle ground? But I'm excited. So with MDMA, so we'll see what happens. We'll see what happens. Now, if you want some spiciness, guys, this is what I'll end it. Then we'll do some Q&A and we'll wrap up for tonight because we went late. We've gone late. We were really insomniacs tonight. If you want some spiciness, go Google right now. What I'm talking about right now, the MDMA failed trial, right, for PTSD. I think the company was called Lykos, Lykos, but I think it was also funded by, I think they're part of a larger consortium called MAPS, MAPS. Type MDMA PTSD rejected by FDA, but then also type sexual misconduct. And you'll see it was kind of a messy process where even as part of this, there were concerns about ethics violations and ethical violations. Again, I used the word accusation. I didn't say anyone was convicted, but apparently there were some spicy accusations at some of the clinical research sites for the MDMA trial, where allegedly one of the treaters or therapists performed some sexual misconduct while someone was under the influence of their MDMA dosing. So that was another layer of complexity and probably not a good look. Allegedly, correct. I said allegedly, but I wouldn't be surprised if that was also something that was factored in as the FDA was there mulling over the data and looking at this. So anyways, all right, guys, we went hour and a half, maybe? Yeah, hour and a half. But let's open it up. Let's the all savor linguistics. You're right. Let's do a few minutes before we wrap up. I still got energy. I think I over caffeinated myself today for some reason. So let me scroll back. Carrie asked several times, psilocybin is very well known, but have you heard of mucimol, a separate psychoactive compound from a mushroom called Amanita muscaria? No, I'm not familiar. I mean, the chemical, I know I've read on it in some of the journals, but I'm not as familiar. So no, I'd have to go look that up. So I'm going to have to get back to you on that one, Carrie. So I'm never going to say I know something I don't know anything about. So I'll have to take a look. What have you read up on that? Just out of curiosity, since you've asked a few times. So I'll have to take a look and take a look at that. But as Carrie's going to comment on that. Thanks, Musics. And again, man, I'm really happy for you, Musics. But what other questions? Other Q&A? I know we didn't get around to TMS. I know we didn't get around to some of the interesting GABA, GABA drugs for postpartum depression, which are also very unique and novel, very interesting. But we'll try to include that in one of the upcoming streams. Not sure if it'll be the next one if we go on a different topic, but we'll see. If we're short on ideas, we'll maybe come back to that. But what other Q&As? Andrea says, I just want psilocybin without THC. I swear, I would be, what do you guys say? I would be shocked if at some point, maybe 5, I don't know if it's close, but I would say I'd be shocked if 10 years from now there weren't some psilocybin dispensaries, right? Just like you go to marijuana dispensaries right now. Like, I mean, I got like 5 of these marijuana dispensaries within a 5-mile radius near my house at this point in Illinois. I'd be shocked if one day, maybe a decade from now, when I'm too old to care, I bet you there's going to be some psilocybin dispensaries where you're going to get to try different variations of different strains, different subtypes and potencies that you could walk in and probably get psilocybin, whatever, edibles, and, all different subtypes of psilocybin. I mean, you kind of see some of that happening right now, right? You have these, shroom companies making these offshoots of legal versions that you're putting in your coffee and this and that. But I mean, I'm talking the real stuff, right? I bet you at some point there is going to be psilocybin. Come to Australia. Everything is still illegal. Do you guys have no marijuana in Australia? Musics. Do you not have recreational marijuana use in Australia, like marijuana dispensaries? KG 10 to the 5 says Muscamilla goes selecta GABA A agonist. Interesting. Selective GABA A agonist. That is very fascinating. And the reason I say that is I know we didn't get around to it, but some of the other medications that we didn't get around to talking about, zuranolone, brexanolone, these are FDA approved as very novel breakthrough treatments for postpartum depression, increase upregulate certain GABA subtype receptors. So it's interesting that you mentioned that mucimil is a selective GABA A agonist. So Music says, Lisa, thank you for joining. Hope you get some rest tonight. Music says, not illegal other than medicinal, and even that's stigmatized. Oh, I didn't realize that. I didn't realize, man, Australia's strict then, huh? That surprises me. I don't know why. In my mind, at least, I thought it was a bit more progressive than us, if anything. So, see, I mean, that shows you how little I know outside the boundaries of the United States. So, okay, well, last call. Starry says, thank you for going into more depth with these newer treatments. No problem, Starry. So, like I said, I try to it's more about education, fair and balanced. Want you to know the pros and cons. You guys out there need to make decisions for yourselves. So, just trying to give you the real meat of, like I said, I'm trying to get into the nitty gritty of cost. Is it cash only? Is it covered by insurance? Can you even access it? All those nuances. So, no, I appreciate you, Starry. So, all right, guys, last call. Going once, going twice. Any other last minute questions? If not, we'll wrap this up. God, we almost went 2 hours tonight, but you guys need to sleep too. That's midnight here. I appreciate you guys. You guys have a good night. This is when it's interactive like this, I have fun. This was fun. I had fun, guys. So I'm going to go to sleep with a smile on my face. You guys have a good night. Spread the word. Have people join. Again, I'll see you guys Tuesday night, 10:30 Central, 11:30 Eastern. We'll get into another topic. But this was fun, guys. Have a good night, everybody. Peace to all of you. Blessings to all of you. Have a good one.